Good morning, everyone. What a beautiful crowd. It's wonderful to be with you, and I'm very happy to introduce our distinguished guest speaker today. Dr. Sandra Stith is a university distinguished professor in the family therapy program at Kansas State University. Her research focuses on partner violence. She has edited 4 books and authored over 120 articles and book chapters on the topic. In 2011, APA published her book, Couples Treatment for Domestic Violence, Finding Safe Solutions, describing a treatment program developed with NIMH funding. Dr. Stith also works with the USAF and Department of Defense family advocacy programs, managing and conducting a variety of family violence-related research projects, including a project to develop and test a risk assessment measure for partner violence, which is currently being disseminated worldwide through the Department of Defense. In 2004, Dr. Stith received the American Association for Marriage and Family Therapy's Outstanding Contribution to Marriage and Family Therapy Award, and in 2007, she received the American Family Therapy Association's Distinguished Contribution to Family Systems Research Award. In 2013, she was named a Fellow of the National Council on Family Relations. Please join me in welcoming Dr. Sandra Stith.
Okay, technology, we got it. I'm just so delighted and honored to be here. It was such a honor when I got a call from Dr. Roby. I appreciate all the generosity and the kindness of the students. I spent the whole day yesterday with Carly and Emily, and we went to the Welfare Square tour, the LDS humanitarian tour, the tour of BYU campus, and I have worked with LDS students since I began as a marriage and family therapist at at Virginia Tech in 1986, and I did not know half of what I learned yesterday. So if you haven't gone to those tours, I highly recommend it. It was very inspiring. You know, we hear criticisms or we hear controversy, but we really don't hear so much about how much good in the world is happening from the work you all are doing, and so I just was honored to be included today, and thank you very much. So I want to do a 2-hour talk in 1 hour. So I'm sorry, I'm going to have to talk really fast. And all of this information is online, will be available online afterwards. I've sent this, I have a lot of numbers in here, and I know we can't talk about all that. So I'm just going to slide over it, and if you want to read it. I love getting emails after conferences, and somebody contacts me and asks me a question. Then I think, oh, somebody listened, it made a difference. So don't think it's a bother. I love it when you say, when I looked at this chart, I couldn't understand what the effect size was or something, but I'm not gonna get into all that because obviously we can't do that today. So what I really wanted to do, I sort of have several different directions that I want to make this talk. First, I want to talk about my own personal experience and how I got into this field. And 2 different research paths which were kind of identified, but one of them is intimate partner violence risk factors. I really felt that as a clinician, we need to know what are those risk markers that we've got to address. And then the couples treatment for domestic violence. And then I started looking at batter intervention in general, the standards nationally and in Utah. And so basically, second subheading of the talk I'm giving today is moving beyond ideology, new understandings of the complexity of treatment. When I started this work, I had such strong ideological opinions about how you do this work and what this means and what domestic violence is, and my life experience and my research has really changed a lot of my thinking. So I'm hoping that I'm gonna help you understand that. I grew up in Oklahoma in a very patriarchal family. There was lots of violence going on. My mother wasn't allowed to work or to even speak out. When I went to Oklahoma State University, I learned that IPV was a crime. I had no idea that intimate partner violence was a crime. I thought it was a right. A husband has to take care of the family, and if the wife does anything offline, that was their right. And so I was really surprised to learn that. And I started thinking that I'm a feminist, which is like a big deal to me because I grew up in a very non-feminist kind of environment. And as a matter of fact, when I got my first faculty job, I called my mom and said, I got a job at Virginia Tech and we're moving to Virginia. And she said, well, doesn't Gary make enough money to support you? Why are you leaving Kansas? I think she thought that all my work in the master's and PhD was kind of a hobby. Well, that's nice for her to have something to do while he supports the family. I really believe that families can only thrive if physical, psychological, sexual violence is eliminated. So my really thinking is about, I feel like I have a mission to make a difference in helping families. And I studied intimate partner violence really with my idea of what my mother experienced and what I grew up learning about. And I really wanted to make things better for women. I started off working at a shelter for victims of domestic violence in Manhattan, Kansas. And I'm now on the board of that shelter, that crisis center. And I learned so much from those women that you could never learn from the research. So how many of you in this audience have done actual internships or real work with domestic violence? So most of you have, and you can hear so much from the research that doesn't fit with your experience, and you've got to validate both the research and the experience, because if you're knowing those people that they're sitting in there and they're telling you their story, that's really a valid piece of research and information. So I learned so much that I am so grateful to that experience. And then I also, in the 80s, while I was a grad student, I taught a course in domestic violence. And I thought, because I was studying domestic violence, I knew a lot about domestic violence. I've been to a million conferences. So why do men hit? What do you think we said in the 80s about why do men hit? The answer was so simple: because they can. Men, do you remember that? Any of you that are older than 25 or whatever? This is what we said. Men hit because we can. We said this a million times. It's because they think they have the right, they have the power, and that is it. Men hit because they him. It's really about patriarchy. And then why do women stay? Back in the 80s, Lenore Walker did some really important research, and she talked about learned helplessness. And she said that women wanted to get out of violent homes, but they couldn't because they got trapped. So every time they would try to get out, there would be some violent incident. So they just learned to just be passive. And even if they could get out, they didn't try, just like the dog in the cage. And back then, when we talked about what is appropriate treatment for domestic violence, it was so 100% clear. And I said this in my class. I still have, let's see, what are those called? Not PowerPoints. Overheads. I still have a whole package of overheads that I would bring out there, and I still have those, as they say on their treatment. And it's all about batterer intervention based on patriarchy and male violence and couples treatment. No, never do couples treatment. And I also so remember saying and believing, not just saying it, believing it, that if you do substance abuse treatment with a batterer, you have a sober batterer. And we now have such really good research from Tim O'Farrell and other folks out there that there are people who, with substance abuse treatment, stop hitting. And of course, there are still relationship issues and other issues to deal with, but I did not believe that. I thought you would have a sober batterer because that just addresses, one of the side effects. But there's some really good research that substance abuse treatment can be effective for some offenders. So all these ideas that I had, I call them now ideology, but they were in our textbooks, and I thought they were the truth. And now we know that there are many reasons men hit, and there's many reasons women stay, and there are a variety of appropriate treatments. And there is a link between substance abuse and battering, and all those are new kinds of information that I didn't used to have. And I have a variety of people who've made a difference in my work besides just my own research. I worked at the family therapy clinics, both at Kansas State and at Virginia Tech, and also in my private practice. And I worked with couples where they were arguing, and I started realizing some of those couples, there's violence going on. I looked at the work of Dan O'Leary and others that we're finding 60, 70%. There's shoving, pushing, slapping going on. And I had the ideology, don't work with couples, but at maybe week 6, I find out there's violence. So then I'm like, well, what do? We send them to the batterer program. Well, why would they go to the batterer program? They're not going to the batterer program. They're going to go to another therapist who knows less about domestic violence than me. And I am very sensitive to domestic violence, and so just saying, you're out of here, sending them to somebody else who knows less, how can that be a good response? And then I had a variety of people who were really influential in my career path. Murray Strauss is one of the leading researchers in domestic violence, and he started doing some research developing the conflict tactic scale in the late 70s and early 80s. And he started finding, looking at large-scale national surveys or college student surveys that both men and women hit. That was like groundbreaking. People thought men are offenders and women are victims. And Murray starts having us start thinking about gender symmetry and gender asymmetry. And that was so controversial. There was even New York Times articles that said, among other things, his wife looked like a battered woman. And his wife was a lovely woman, and she was not a battered woman. Just take a look at somebody's wife and say, she looks like a battered woman. I mean, they were so much criticism against him. One of the New Hampshire domestic violence conferences I went to, a whole group of women stood up, not just women, but strong feminists, stood up and walked out of that conference because he started talking about women's violence. And that was just heretical, that you would say that women would be violent. So there I am sitting there trying to figure out, where does my ideology go and my treatment thinking, and where am I? And then Michael Johnson comes along, and he's from Penn State University, and he is also a strong feminist, but he started looking at big data sets and trying to understand Murray's ideas about gender symmetry, and he ended up deciding that there's different types of violence, that all violence is not the same. So when you look at gender symmetry in men and women both being violent, that's more likely to happen in situational couple violence, where it's not about power and control, but people argue over a certain situation, what to watch on TV, how to spend money, variety of issues that we argue about during the day, and it ends up with shoving, pushing, slapping. And that's different than power and control that ends up with intimate, part of intimate terrorism. And he's the first one to really say we need to make distinctions. And that really kind of led the way for me to think, yes, there is a role for social workers, family therapists, working with couples when there's domestic violence, because there are different kinds of violence, and it's not all the same. And of course, intimate terrorism, when a wife is terrified for her life and afraid to speak freely, wouldn't be appropriate. Now, I'm going to obviously talk more about that work later, but so I started doing meta-analysis work, and that was back about 2000. I started trying to look at all the research there together to find out what were the risk factors. My dissertation had to do with risk factors, but we had a lot of individual studies. So I started trying to combine them and and I've done many meta-analyses, and I'm in the middle of many. So I looked at lots of different databases. I looked at the article reference list and found out what was being presented at conferences. But one of the things that's so interesting to me, in the 2002 paper, we had 85 studies that we were able to include. In the 2016, we have 658. So that just shows you the phenomenal increase in quantitative research in the area of domestic violence. In 2002, we were only able to calculate one effect size for female perpetration. There was only one study that had a quantitative number that looked at female perpetration. Now we have 615. We weren't able to collect any effect sizes for male victims, but now we have 418. And so altogether, we have a sample size in our data set right now, and that's probably a year behind, but 1,637 individuals, 431. So it's huge, and we keep adding to it every day. The reason I'm talking about this is because I want to talk about the diversity of causes or correlates of domestic violence. So when you do treatment, it's not as simple as patriarchy. So when you have a large effect size, according to Cohen, it's 0.50, 30 to 50 is medium, and 10 to 30 is small, and less than 10 is very small. So I'm going to talk about some of the strongest risk markers from this large data set. We looked at lots of different factors. We looked at contextual factors. We looked at individual factors. We looked at more individual factors. I mean, a lot of these haven't even been published yet, but we looked at family factors, relationship factors, and history of violence factors. So I didn't, I want to encourage you to go to those articles, go to those online to look more at them. But I want to just say, what were the strongest risk markers from this huge data set for each of these categories? So under contextual factors, some people will say, people are violent because of their social class, because of their stress, because of their income. These are very small effect sizes. The low education, income, stress, age, those are very small effect sizes. So the context that people live in, not to say that it's not important, because all these things are important, they're significant. That's all significant. But when you have data set as big as mine, you're going to find pretty much everything significant. But those are small effect sizes. When you look at individual factors, those mental health factors are medium effect sizes. They're much more important than those effect sizes related to stress. So like borderline personality for perpetration, it's a medium effect size. Use of power and control, anger, approval of violence. So those are variables that if you were going to do a treatment program, you need to look at mental health factors, borderline personality. We also have victimization, and those could be causes of perpetration. They don't need to, they're correlates, so they're not necessarily causes. So you have PTSD, fear, substance use, and depression are the strongest individual risk markers for victimization. We've also broken this down, of course, by gender, but I'm not talking about that today. When you look at child and family factors, one of my first papers I published recently from this meta-analysis was on these factors, because I've had students over the years who are afraid to get married because they grew up in a violent home, and they have this idea that if you grow up in a violent home, you'll be violent or you'll be a victim. And that is so not true. That's definitely a risk factor, but we know lots of people who grow up in violent homes, like myself, who end up being more resilient and more careful and thoughtful about their mate choice, the way they deal with conflict in their families, getting therapy if they need help before they get to a point where, so just the fact that you might be more aware of the potential if you grew up in a violent home, it doesn't mean you're going to be violent, but those risk factors are small to moderate. When you look at relationship factors, they're also small, moderate. Things like verbal arguments. So couples who argue are more likely to have violence. So if you're violent, if you argue with your wife and you're having arguments, you're more likely to be violent. So one of the issues to me, these relationship factors are important. Communication, and infidelity can be perceived infidelity. It doesn't necessarily mean actual infidelity. Low relationship communication. So one of my messages I'm going to be repeating during the day, if you're going to be doing offender treatment and the couple stays together, at some point these relationship factors got to be addressed also. And then the history of violence is the biggest factor. And one of the most important things I want to highlight is the issue of if you look at victimization, the strongest risk marker from all that we've looked at for being a victim is previous IPD perpetration, which it can mean self-defense. That's one of the challenges with the conflict tactics scale. But it also can mean bilateral violence. And so when you're, one of the things I've really spoken strongly about is when you have both people being violent, we see so many times in our community, I don't know what's happening here, we send the male to the offender treatment and we send the female to victim support treatment even though they're both being violent. And the biggest predictor of the male, this in another data set, but perpetration is if you're hitting your partner, there's a strong likelihood that you're going to get hit also, whether it's self-defense or whether it's not self-defense. So to me, both partners need to figure out ways to handle relationship conflict non-violently. So overall, we found that of the 60 risk markers, 31 for victimization, 80 were not moderated by gender. So it didn't matter if you were male or female. Only 5 with perpetration and 4 with victimization were moderated by gender, so it made a difference. I'll just real quickly show you these ones. Young age is a bigger risk marker for men than it is for women perpetrating. This is for victimization. Young men are more likely to be victims than young women, or it's more likely to be a risk marker. Depression, all the work we've done, we consistently find females having more depression, victims of violence than males. Alcohol problems, significantly more of a problem for female victims. I wonder if that's self-medicating. That's what I think about, but I don't know. Victim of forced sex, by far, women are more likely to be victims of forced sex, and that's more likely to predict they're being a victim of physical violence. And child abuse in family of origin is a bigger risk marker for women being victims of violence in their relationship later. And for perpetration, abuse in the family of origin is a bigger risk factor for men being perpetrators, for women being victims. Could be because the men observe their father be violent and women observe their mother being victims. Alcohol use, again, is a bigger predictor for men being violent than it is for women. Previous perpetration is a bigger predictor for men being violent, but look at how strong those effect sizes are. For both men and women, previous perpetration predicts subsequent perpetration. You know, once you've hit somebody, there's a likelihood you'll hit them again. Physically abuse own children, higher risk factor for men who are offenders. And demand withdraw communication patterns, bigger risk factor for men, which I think has to do with that power and control kind of issue. So what I want to say that this means to me, this piece of this work, is that intimate partner violence is multifactorial. There's not one cause. You can't have a simple treatment program that addresses everything. And that the risk factors for males and females are very similar. Relationship factors, prior history of perpetration, victimization are the strongest markers for both perpetration and victimization. But of course there's limitations to everything. One is that these studies put all the research in together, no distinctions made. So we've got, some of our offenders in these studies are intimate terrorists, and some of them are situationally violent. So we're doing a project right now, we haven't published, but it is, we're looking at the strength of the risk markers for samples that come from batterer treatment programs and victim support programs compared to the general population studies. So we think that there'll be more intimate terrorists in the Batterer program and more situational in the community samples. And we found, just like what we thought, jealousy, use of power and control, belief in male privilege were higher in clinical samples. So those are factors that when you're running a Batterer program, or you're running a prison program, or you're running a program with folks who are court involved, you're more likely to see that type of violence. That's what we're finding in this big meta-analysis. But when you look at the community sample compared to those people in clinical samples, there's not any difference in relationship satisfaction, demand withdrawal, communication, conflict resolution. So those factors, even though they're present in both groups, to me, I keep saying they need to be addressed also. So this new project, to me, supports Michael Johnson's work that there is something different about intimate terrorists than situational couple violence. And both kinds of, that the treatments need to target what kind of folks are in the programs. I'm going to really quickly go through this. We also did an international meta-analysis and looked at individualistic versus collectivist countries. And these are the collectivist countries that we looked at. And these are individualist countries. So in total, we had 223 from the United States, and we had a total of 960 and 481,000 individuals. Overall, again, the relationship markers and the history of violence were the strongest risk markers. The same as in the US, they're the same. But culture, whether they were collectivist versus individualist, mattered. And 5 of the 11 male perpetration risk markers differed by culture. I'm not going to talk about all those, but I might bring up one that I thought was pretty interesting. I've been doing some work with some folks in Canada, and when we found that the issue of problems with alcohol was a stronger risk marker in US and in collectivist, but a less strong risk marker in other individualistic countries like Canada. And a lot of the studies were from Canada. So I called the people in Canada, and they said, the social workers, people I was working with, they said, oh, well, we don't really use alcohol much in Canada. We use herbs. And I thought they were talking about parsley and sage. And I'm like, herbs. I was thinking like herbal treatments, but they were talking about marijuana. They said that alcohol is too expensive in Canada, so I didn't know that. So just trying to understand these things is sometimes the culture, especially if you don't understand the culture, it's hard to understand why. And we're doing a project right now that looks at income inequality, because we found so many times the U.S. looked more like collectivist than individualist, and U.S. is like the highest on the level of individualist. So why do we look more like collectivist? We think it might be income inequality, so we're looking at that now. So, but overall, there's a multitude of factors. There's also cross-cultural factors. We need to understand not only the folks that are coming to your programs here in Utah, but also what's happening internationally, how we take our programs and adapt them to be more culturally relevant in other countries, because culture matters, gender matters, and the individual factors, the mental health factors, the relationship factors matter. The second main focus of my work has been on couples treatment for domestic violence. And I started that work because I realized we were seeing couples and we had no idea what to do with them. And I wanted to make some evidence-based program. And I'm not going to really talk about that right now, but just highlighting that I believe that treating male violence without treating female violence can increase the likelihood that male violence occurs, that there's no treatment approach that's been documented as the best for everyone, and also that relationship conflict is a part of predictor of domestic violence. Couples, as we all know, oftentimes want to stay together. It's not about learned helplessness. Increasingly, we know that there are a lot of couples who want to stay together. but they want to stay safely. Nobody wants to stay in a violent home. Everybody that wants to stay together, they want to stay in a safe home. And even if, in some communities, they're finishing the offender program that's state mandated and then doing the couples program. And that's another logical way to do it. So making sure that you get both the couple who wants to stay together and the offender. I also know, and I talk a little bit about that later, but victims can be empowered by having a therapist sit there and help them listen and challenge some of the ideology and the thoughts that are happening. Relationships can be improved. We have a lot of data on that, and that different couples need different types of treatment. I've also looked a lot at offender programs around the country and done a lot of thinking about what is being used and required across the world and across the US. And Roland Mayoro did some interesting work looking at batterer intervention standards. And at that point, he said 91% of all the standards were one size fits all. That everybody is supposed to use this particular. In Kansas, Haley has a program called Family Peace Initiative, and everyone in all the offender programs in Kansas are mandated to use that program. Only one state at that point required that there be some evidence behind the program that they did. And couples therapy was outlawed, and only 20% of the states allowed couples therapy, whereas about 50% had allowed it 5 years earlier. So the allowing of couples has decreased, as has allowing of individual sessions. And for many communities, not allowing individual sessions is very difficult because you might have a group start and you have to wait a really long time before the next group starts if you don't have enough clinicians to meet the need. So it's a challenge. So I thought it would be interesting to kind of, as I wrap up and think about how, I thought it would be interesting to look at what's going on in Utah. And I found this from the Michigan National Batterer Intervention Program website, so I hope it's accurate. But in general, when you look at what works with domestic violence treatment, we really have very little evidence. I'm very excited that Dr. Casey Taft is speaking today. He has some really nice work on a trauma-informed batterer intervention and domestic violence work that I think does have some nice research. And there's some other programs, but when you look at the meta-analyses that have been done on batterer intervention programs, we don't have very strong support. We're spending a lot of money on them, and we really need more evidence, more research, more clarity, more targeted treatment. And they're beginning, programs are beginning to look at targeting treatment. So one of the recent articles I read, like in particular preparing for this, was Principles of Effective Intervention in the Criminal Justice System. And they were applying those effective intervention principles to batterer intervention programs. And they highlighted that the first thing that leads to effective intervention in the criminal justice system is careful risk assessment. Second is targeting and assessing needs to reduce recidivism. And third is responsivity, like being responsive to the participant needs. And so I thought I would look at how those standards and what the article said about batterer intervention programs compared to the Utah standards. So do the Utah standards reflect principles of effective intervention? So according to these authors in 2016, they said that batterer intervention programs typically require for the treatment provider no substance abuse problems, nonviolent lives, non-sexist attitudes, and the training of staff is about 50-50 across the states regarding licensed or on-the-job training. So when we were at Virginia, a lot of our grad students ran batterer intervention programs in Northern Virginia when they didn't even have a master's degree. And a lot of programs around the country allow anybody who is, some of them really like formerly battered men to run the groups because they understand the situation. But in Utah, individuals providing DV perpetration outpatient treatment services should be licensed in accordance with the Mental Health Professional Practice Act, which I thought is good. I looked at that as a positive thing. And that they also have to document specialized training in domestic violence assessment and treatment for all individuals. So they have to have 24 hours of pre-service training and 16 hours of training annually in domestic violence. So they're not just taking MFT or a social worker, and they do specifically say social worker, MFTs, counselor, psychologist, but also people that know something about domestic violence. So this seems like a smart approach. And then in the article about, they say, Raditz and Wright say, batterer intervention programs are aware of factors that affect treatment completion. However, programs continue to treat batterers as a monolithic group. And that is exactly my experience, that there's a 26-week program, which some states like California requires, and they think that's so much better than the 12-week program. And you know, we argue about length, but we treat everybody the same. And so, whereas in Utah, client needs for psychiatric consultation or treatment for substance abuse or other co-occurring diagnoses when indicated and documented in the case file shall be addressed by the treatment provider through appropriate referral or by limited integration of such conditions into the domestic violence treatment process in compliance with the provisions of this manual. That's exactly what I would want in a program, that it would not just say, follow Haley's 18-week model, and week 7, every single offender gets the same thing. So this is really saying targeted treatment. Now, you all work in Utah, and some of you say, well, that may say it doesn't happen, but I'm just from the outside looking in, I'm like, that's good. Regarding couples treatment, the Utah standards say, couples counseling shall not be utilized until an assessment has been conducted which indicates the victim is at low risk for engagement of further abuse due to the counseling. The taking responsibility for his own, they must document that the abuser is taking responsibility for his own behavior and that all forms of physical abusive behavior are stopped. In addition, it shall document that the victim is not taking responsibility for the abuser's behavior and has acquired sufficient assertiveness skills to state her needs in the relationship. To me, this is, there is this general idea that it's his and hers, which we know is not necessarily true, but in general, the idea that you don't start couples therapy until you know that it's safe is smart. And then I also really love the second one, which is not true in so many states. There are so many states that do not allow even a single meeting where they're conjoined. And I think that is one of the biggest mistakes. This section does not preclude brief meetings conducted jointly with the victim and the perpetrator for the purposes of explaining or informing the parties about such matters as program procedures, behavioral contract provisions, or anger management techniques. So in the work I'm going to talk about this afternoon, we have a really strong component of negotiated timeout. And what we learned was all these women who had been to the men had been to the batterer program, and the women who came to our program found that the timeouts that were being taught in the batterer programs and being implemented in their home were abusive. That the men would just say, taking a timeout, I'm on a walk, I'm leaving, I'm out of here. And the women wouldn't know what the rules were, what is a timeout. They're trying to help and support the batterer, but they don't understand what he's doing. And so having joint meetings, to me, at the least, when you're teaching new skills of meditation, mindfulness, timeout, whatever, how can you teach one person and the other person's supposed to implement those skills in their relationship without teaching the other? So those brief meetings where the partner learns what's going on just really seem like the logical thing to do. But a lot of standards around the country say absolutely no meetings between the partner. Like as if I'm sitting here as a therapist and I'm sitting there meeting with these people and talking about timeout would be more dangerous than they're going home and living together every night and every day. But Utah standards allow that. They also encourage a cooperative relationship with the domestic violence shelters, victims and partners, and to me, one of the most important principles is that coordinated community response, so that none of us are working in isolation. So if we're doing treatment with an offender or a victim, we're working as a part of a coordinated community response, and that's like number one on my list, and I really like that. That's not always happening. And then that in-depth assessment is also highlighted here, and I think you can't possibly assess an offender unless you gather a lot of data. There's a lot of people who come in, like a student does a quick intake, and then the group starts Thursday, and they start week 1, and they do 26 weeks or 18 weeks, and we don't know anything about their mental health status or anything. So my conclusion is that intimate partner violence is multi-causal, that it's not one-size-fits-all treatment, and that patriarchy is not the primary cause. It might be in some situations, but it is definitely not. We have a lot of data to support that, experience to support that. It's important to move beyond one-size-fits-all. It's really important that our communities need to consider and continue to look at evidence-based work. That's why this conference is so exciting and so important, that you're looking at a variety of different approaches. You're not just teaching one model that everybody's supposed to use for every person. And I also think you should be proud that the Utah standards do reflect a focus on targeted treatment, professional providers working with expertise in both treatment and intimate partner violence. So, thank you. So what kind of questions does anyone have? I zip through that thing. What do you want to ask?
Define intimate terrorism.
Intimate terrorism, that's a really good question. It's really the kind of violence that's based on power and control. And so some of the intimate terrorists are controlling everything that the partner does, and the partner lives in fear of any way disappointing or upsetting the husband, as opposed to a normal couple who argues and disagrees, and one of them may throw the remote across the room, and the other one, there's that kind of back and forth. By far, situational couple violence is much more bilateral. And in intimate terrorists, it's partners living in fear. And fear is a huge factor in intimate terrorism. Was that clear? It's not as simple as, it takes careful diagnosis and assessment, but yes?
Can you go into a little bit more about why the United States would be considered collectivist?
Oh, no, it's individualist. But why the data, when we looked at the risk factors, we looked at U.S., international, individualist, and collectivist. And the reason we did that is because U.S. had so many of the studies. We did it in 3 groups rather than 2 groups. And at least half of the risk factors, U.S. was more strongly related as far as the strength of the risk factor to countries that are collectivist. And we thought we would be individualists. And so a lot of the countries that are considered collectivists in Hofstede scale are developing countries. And so why do we look more like developing countries? So I started looking at income inequality and gross domestic product, and we have a paper under review right now that U.S. is high on income inequality and also high on individualist. So is it the individualism that makes those risk factors more prevalent in the U.S. or is it the income inequality and the people who see other people around them having so much more than they have? Does that make sense? Sort of a new area for me, but we just couldn't figure out that results of that study. Other questions?
Does Johnson or anybody since then try to describe this demographic by percentages of those three groups? That they think how many domestically violent situations are in the terrorism resistance or?
I've seen those data that says, and it's by far situational. Intimate terrorism is much smaller, and it's mostly male offenders, and then the reactive violence is more likely to be female offenders. And then there's a small group of people where they're both terrorists, and that's really small. And those are, a lot of them are borderline personality disorder, severe narcissism, severe mental illness related factors.
Can you speak to the difference in treating couples that are labeled as high conflict couples versus couples where one individual is dealing with mental illness or substance abuse and it's not truly a high conflict couple, but an individual?
That's a complicated question. You know, when we work with substance abuse in, you know, where we work, and high conflict couples, highly related. And for some people, reducing the conflict can lead to reduction in alcohol. But for some people, they've got to have the alcohol addressed. And then mental illness, whether it's co-occurring and that needs to be treated at the same time you're doing the couples work. I mean, that's, to me, part of it is why we need a coordinated community response. So one person in private practice working with alcohol and serious mental illness and high conflict couples, and so like a team that's addressing issues based on, especially as you see that until we address the trauma, we're not going to make any difference with the other work. And so, yeah, so looking at what the unique needs of the individual. I don't know if I answered your question, but I'm saying it's complicated, which you know.
Is there any research showing that violence is increasing overall?
I haven't seen any research saying that it's increasing. We have some, we're doing, my doc student, Chelsea Spencer's doing a meta-analysis of intimate partner homicide. And it's very interesting to me that the rate of male to female violence has decreased in the past, not violence, homicide, has decreased in the past 10 years, but the rate of female to male, no, it's the other way around. The rate of female to male has decreased, but the rate of male to female has increased, and the authors of those papers suggest it has to do with more services being available. So rather than use self-defense and kill their partner, women are seeking shelter, so they don't have to resort to killing. So there is a women to men killing lower in the last 10 to 20 years, but men to women killing has not decreased, it's remained steady. But I don't know about the rate of partner violence. It's getting really harder, and maybe those of you who are researchers know this, it's getting harder to do large-scale national studies. People used to pick up the phone when the Strauss team was working and answer and talk about their violence. Now we see this is a number we don't recognize, we don't even pick up. It's a telemarketer, and so we do a lot of undergrad student, large-scale studies, but to do those large-scale national studies, my students are using MTurk and doing Amazon studies now. And are you familiar with that? They're getting hundreds of people in no time, but who are these people that spend the day on Amazon answering surveys? So I don't know how representative they are, but they get their numbers really quickly. Do any of you do MTurk in your spare time? I'm just curious. Anybody does MTurk? Did somebody yes? Okay, good. Well, I didn't know who does that.
We have time for just one more question. a final question, and also remembering that Dr. Stith will be doing a session this afternoon on relationship therapy. So, okay, maybe it can wait. Thank you so much, Dr. Stith, so much.